I am Dr. Simarro from the Instituto del Lipedema Madrid, and starting off, I want to say that over the last 2 weeks we have completed a work that will be published in a medical journal, hypothesis medical journal, that will explain once and for all why the lipedema emerges, why it hurts, why sometimes it doesn't, why it develops in some areas and not in others. In short, and in collaboration with Mrs. Karen Tet, we will publish in a few months these hypotheses that will change completely all of the theories revolving around lipedema. Once published, it will be free access for all practitioners from all over the world can better understand how lipedema develops and why it hurts and it gets worse over time. So well, now we will see which are the main diseases associated with lipedema. First, we will talk about lipedema, what that is, a short introduction, lipedema, according to our definition, is a chronic inflammatory disease which produces an increase in the number of fat cells that is called hyperplasia, and it produces inflammation of the cells that increases the volume that is called hypertrophy. These hyperplasia and hypertrophy will produce neuropathic damage, lymphatic damage, and vascular damage. Depending on the areas in which lipedema emerges, the damage can be lymphatic in some cases. In other cases, it will be vascular. Sometimes the damage will also affect the arterial system. This pathology usually occurs exclusively in women, with a prevalence between 10 and 18% according to different studies. At the beginning, it affects the lower extremities of the body, but over time it could extend to the arms and to the rest of the body. On many occasions, lipedema can be painful, can hurt. It is a common feature of this disease, the fact that it doesn't respond to diet or exercises. Since it usually generates at the beginning in the lower parts of the body, that will produce a disproportion between the lower and upper parts of the body, as this is one of the main features of the early phases of lipedema. Other symptoms that may appear are pain and a feeling of tiredness and swelling in the legs, which may intensify with heat and menstruation. For many years, still today, lipedema has been misdiagnosed as obesity, lymphedema, and oftentimes at the beginning it is diagnosed as cellulitis. However, this is wrong because according to WHO, cellulitis is something different, and in 2018 it was recognized under the heading EF02 as some non-inflammatory disorders of the adipose panicles. However, it is now believed to be an inflammatory disease. What is lipedema? The main symptom is an increase in fatty tissue in the lower extremities, which usually starts in the muscle or in the calves. It usually starts in the muscle and then it will extend to the rest of the leg, and over time it will extend to the arms, and oftentimes around menopause it will affect the back and the waist. Which is why the features of women with a small waist, that specific characteristic will disappear because that zone, that area will get fatter, and which is also why this disease is misdiagnosed as obesity. On many occasions, 50 or 60 years old women who started with lipedema in the legs, when it extended over the rest of the body, they were diagnosed as obese, and that lipedema will definitely affect the whole body. As it is a lipedema, it will not respond to any diet. So this obese woman, 50 years old, with pain in the back, which doesn't respond to the diet, and was not believed by most of doctors, she actually has a pathology. The prevalence of lipedema is not well known. but according to various authors, it would be between 8 and 18.8% of these cases. In other studies, they talk about 10 to 16%. 1 out of 7 women has lipedema. In its early stages, lipedema is diagnosed as cellulitis, and in its final stages, it's gonna be diagnosed as obesity, which is why way fewer lipedemas are nowadays diagnosed. Lipedema is quite rare amongst men, and when it has been described, it has been associated with hormonal or hepatic diseases, with androgen depletion being a common cause. Although it has not been demonstrated that lipedema is always hereditary, all of the practitioners and scholars studying lipedema, we think that it is indeed hereditary. Different studies carried out says that between 16 and 64 of the cases, they were shown that there is an hereditary factor. In our experience, approximately in 68% of cases, the hereditary is paternal. So the first thing we have to look at is the mother of the father, the paternal grandmother, and at the father's sisters. But in 32% of cases, the hereditary is maternal, which is why we will have to look at the mother and at the sisters of the mother. Types and degrees of lipedema. Singer in 2003 gave a classification of lipedema depending on the areas in which it develops. And we can see here that if it develops mainly at the level of the hips, it would be type 1. If it develops at the hips and in the muscle of the legs, it's gonna be type 2. If it develops at the level of hips, leg muscle, and calves, it's gonna be type 3. If it also gets to the arms, it's gonna be type 4. If the lymphatic damage is advanced, the lipedema affects even below the ankles, and a lipedema appears. At the Instituto del Lipedema, we found 2 types of lipedema that had not been described by Shingo. The lipedema that affects the arms, and especially the lipedema that affects the calves at the beginning. This is the characteristic of lipedema in thin women, And it's very important to note that because many patients who have this lipedema are not diagnosed as such as women with lipedema. And in our experience, the lipedema that affects calves is the most painful than all. Meyer, Wohlrath, and Schmeller in 2004 created another classification based on the volume. And when we talk about volume, we talk about the small fat bags that appear below the skin. And according to that, there will be type 1, degree 1, not much affected, type 2, degree 2. The person will be affected to a point in which these fat balls will look like small beans that you can't pinch with your fingers still. And third degree, these fat bags, these fat balls will look like apples to a certain degree. This is the maximum level, the maximum degree of lipedema. That being said, let's start with the diseases associated with lipedema. The first disease associated with lipedema is intestinal hyperpermeability. In fact, this is the inflammatory disease that triggers lipedema. All of the women with lipedema have intestinal hyperpermeability. What is that? Basically, the intestine acts as a barrier or filter, a colander, with very small holes. These small holes, tight unions, allow the absorption of nutrients only through the intestine. But women who have lipedema with some types of food, the intestine will get inflamed. And when it gets inflamed, the small holes of this filter, of this colander, will get bigger. And with such huge holes, also bacteria, viruses, fungi will pass within the system. Not only nutrients. The passing of all of these bacteria and fungi will trigger a reaction from the immunitary system that will recognize them as external objects and will attack them. And that will produce a chronic inflammation of low level. Because of that, all of the women with lipedema in an advanced phase feel heavy, feel full, a sensation that has nothing to do with the real consumption of food, because the substances that pass through this colander, this filter with bigger hole will produce an inflammation. Which are the diseases that produce hyperpermeability? These are related with gluten, mainly gluten sensitivity slash non-celiac wheat sensitivity. But why do we talk about non-celiac wheat slash gluten sensitivity? Because today we know that cereals like wheat, barley, and rye also carry other inflammatory substance that is called ATIS. ATIS means amylase and trypsin inhibitors. The inhibitors of amylase and trypsin are as harmful to our system as gluten. So many patients who quit eating gluten but still eat wheat and other types of wheat will still have the inflammation because buckwheat has ATIS and because oats has a substance that is called avenine. And avenine is a prolamine. And gluten is another type of prolamine, which is why oats
and also maize and corn are pro-inflammatory. So other than gluten-associated diseases, which are celiac diseases, we also have reported non-histamine-mediated allergy to gluten. What does it mean? If it is not histamine-mediated, it means that despite there is an allergy, the reaction is not immediate, is not as quick as in other allergies. We better say not AGA mediated, so histamine and these substances do produce these acute reactions in allergic subjects, but this allergy, which is not mediated by these substances, are not immediately expressing themselves or manifesting as allergies. Also, the eosinophilic esophagitis, gastritis are triggered, eosinophilic enteritis, which are pathologies which have non-AGA mediated allergic infections. Other diseases that might occur due to this intestinal hyperpermeability are other kinds of intolerances. And here we need to make a digression. Intolerances can be inherited or acquired in time. Hereditary ones will stay forever. Acquired intolerances are due to the fact that our system, our microbiome is changing, and also the digestive system that's change. So for this reason, certain kinds of food that would normally not induce inflammation, once the microbiome is changed, once the intestinal wall is injured, these substances that were not injuring at the very beginning then become injuring. Talking about intolerances, for which, with an improvement of the intestinal wall and with an improvement of the walls, we can have the subject improve. We can lead to the disappearance of this disease, which is, of course, very good. Intolerances to these foods are usually acquired. And when a patient is improving at the level of hypermobility and the microbiome, these intolerances could even disappear or be reduced. These intolerances to agglutinins, lectins, and saponins. The dysbiosis is a change in the intestinal microbiota when a cell being normal is transformed into a pathogen and inflammatory agent. This change at the level of the microbiota can happen in different parts of the intestine, in the small tract or in the bowel. So one of these kinds of dysbiosis is SIBO. It's an overregulation of bacteria in the microbiota of colon and small intestine. So it's another kind of dysbiosis, but it's still a dysbiosis. Moreover, another pathology that is leading to hyperpermeability is intolerance to lactose. For the production of lactose that is abnormal because over the years the intestine stops producing lactose. We are the only mammals who drink milk at an adult age, so our intestine is ready for milk when we are little children. But when we grow up, we do no longer produce and we are no longer prepared with our intestine. So except for some populations in North Europe, generally adults do not produce lactose. And so lactase, that's the enzyme contained in lactose, is not produced. So this is going to be metabolized by the pathogenic microbiota that is going to trigger an inflammation. Other intolerances could be due to milk, protein, and casein. This could lead to an inflammation provoked by this abnormal production. I would like to clarify that the fermentation and the transformation of milk, not in all products, like in fresh cheese, the lactose is not present. So those who are not intolerant to lactose can eat certain kinds of cheese, which is seasoned cheese, but not fresh cheese, which still contains lactose. So moving on. Intestinal hyperpermeability. This is a very interesting layout in which we can see how the intestinal walls are formed. You can see that there is a layer, upper layer of enterocytes in light blue, which is protecting us from bacteria that are present in this part, which cannot penetrate. Anyway, if they can penetrate, they're going to do this through these tight junctions, the little holes of the stringer I was referring to. So they pass through these areas that are called lamina propria, and so the immune system is going to recognize these substances, bacteria, LPS, as foreign substances. So it's going to attack these substances, and in doing this, they're going to produce an inflammation. This chronic inflammation, which is not acute, it's a characteristic of the hyperpermeability at the intestinal level. This hyperpermeability does not only provoke an inflammation in adipose cells in lipedema patients, so it's inflammation of a different kind. It's going to provoke an inflammation also to the rest of the body, and so symptoms are going to occur, and these symptoms going to involve, as we said, the whole rest of the body. Here we can see that through these tiny holes, these substances can pass. These substances are wrapped in the ducts of the intestine, which is sort of filter the liver, and then they can damage the liver and can produce a pathology of non-alcoholic fat liver. So besides from this filtering action of the liver, they can pass through the rest of the body. They can reach the adipose cells and can inflame, provoke an inflammation of the cells. They can also reach the muscle cells and also muscles. An inflamed muscle cells is a cell which does not respond to exercise. That's why many women with lipedema do actually practice physical exercise. There's no reaction at the muscle level. That's the explanation, because also muscle cells are affected by this phlegosis. General symptoms of intestinal hyperpermeability do express themselves through a feeling of fatigue that at the beginning starts at 6 or 8 in the evening. It's this sense of being over exhausted. Even then, they've not been working a lot. These women would still feel tired and fatigued, and once they go to bed, it's not easy to fall asleep. And it's going to be a very superficial sleep. It's not a regenerative sleep. It's very superficial. So despite they sleep 8 hours, they still wake up tired. This is quite frequent to have headache, other kinds of pain, migraines, and due to the production of serotonin, depression, and anxiety due to the lack of this substances. A 20-year-old woman with lipedema has just a few of these symptoms, but after 20 years, progressively, this woman would feel the symptoms much more. Fatigue is increasingly present the whole day long, difficulties in falling asleep, a very light sleep, not deep sleep, difficulty in managing sleep, joint and muscle pain. So all this is part of the symptoms of intestinal hyperpermeability. According to other studies as well, so not only based on our experience,
depresión, migraña, un 23 y un 21%, y alteración
34.4 allergies, 23% depression, 21.5% migraine, and sleep disorders for 21.5. Finally, the symptoms get worse with age due to the fact that an increased number of fat cells are inflamed. There's a higher percentage of inflamed cells, so we have a lower response to diet. When women affected with lipedema are aged 20, the adipose inflamed cells are the cells of the legs. That's why legs are not going to respond to diet. Or maybe the adipose cells of arms and the trunk are not inflamed yet. So at that moment, these areas are going to react to the diet. With the progression of the disease, the arms start to be fatter and will start not to respond to the diet. Finally, around 45 or 50 years, lipedema is going to involve the trunk, fattening the hips, the waist, and the arms are no longer responding to diet. Other symptoms that increase with age are the weight gain that is not explained. Many patients and their physicians, nutritionists are not living in their patients that despite reduction of calories through the diet, there are no improvements, there's no reaction accordingly, so they are not believed. In English, there is the expression of fogged mind, that's confusion in thinking. So based on what we eat, if it is an inflammatory food, even if we had a very low intake, but if it is a pro-inflammatory food, it's going to provoke retention of liquids and an immediate gain of weight, especially in the lower part of the abdomen. Moreover, also the joints, abdomen are affected, and there is a feeling of fatigue and tiredness. Another lipedema-associated pathology is ligamentous hyperlaxity. In our experience, in 96% of patients, so almost all women affected with lipedema, there is this ligamentous hyperlaxity. This pathology is associated to the Erdentalis syndrome. It has been called hyperlaxity, and this is still debated because in the rest of the other early Dallas diseases, there are some alterations at the level of the DNA. Anyway, in the ligamentous hyperlaxity and in the earliest Dallas, this has not been confirmed. So that's why, according to many researchers, the syndrome of ligamentous hyperlaxity does not belong to the spectrum of earliest Dallas. It has been called ligamentous hyperlaxity because the physician who coined this word thought it was a venous pathology, the benign one, but it's not true. Over the years, it's going to injure joints increasingly, and it's going to become much more dangerous. The Bader's test helps us in the diagnosis of ligamentous hyperlaxity. So we can see if the thumb can touch the forearm, if the little finger can be twisted backwards, and if the elbow can be twisted on the other side, if the knees can be curved internally. And in young lipedema women, whether not aged, well, during this period of youth, they can touch with the palms of their hands the floor without touching their knees, without bending the knees. So what is the cause and also the consequences of hyperlaxity? According to our experience, the ligamentous hyperlaxity involves especially joints which have to bear weight. So weight-bearing joints like the lumbar spine, hips, knees, the ankles, and the plantar area. The lumbar column has an hyperlordosis due to the extended torsion, and women with hyperlordosis have some traits in common. When they were young, trousers would never fit properly, especially at the back. But with the evolution of this disease and with the passing of years, they start to notice feelings of overbearing the back, the lumbar area when they lift weights, a suitcase with no wheels, the spine is overcharged, and there will be a lumbalgy over the years and different inflammations. So with passing of the years, especially with obesity, there will be probably disc hernias and also other pathologies like protrusions, disc protrusions. Also the hip is affected. And this is not rigid and fixed with ligaments, so it over-rotates. So the anti-rotatory muscles do surround the hip, and these muscles that are not intended to perform this excessive rotation, this leads to repercussions to the gluteus maximus muscle and the tensor muscles, so they're going to be injured. And due to the fact that these muscles are anchored in this area, there will be a bilateral trochanteritis. So we focus on this area. We know that women can feel severe pain. Also, the iliotibial tract is going to be injured. So if we follow this trajectory, we reach the area of the knee. It's going to be very painful for the patient. Also, the knee is affected. But why? Because the knees in the lower part, the level of the rotula, they do rotate into space, and these areas are protected by the cartilage in order not to wear out. But if the ligament is not keeping the rotula properly, there will be lateral displacements. It's going to lead to areas with no cartilage that are not intended to be in this way. And so it's going to be the onset of injuries at the level of the rotula and also bone injuries. A condylomalgia patella. So a characteristic, the main characteristic of this disorder is that impact sports and like running can generate pain. Knee bending or bending on one's legs or knees, all these movements can generate pain. Also, squatting down or kneeling down is going to be extremely painful. Let us move on. What happens at the level of the ankle? Ligaments of the ankle keep the bone of the ankle in the right position. In these cases, the ligaments of the ankle are not that rigid, so there's a higher instability. There will be a greater torsion, especially under movement or effort of the level of the ankle. This could mean when walking on heels or on a irregular surface, the ankle is going to be twisted at roughly 90 degrees. And so the ligament, in a way, is not breaking, as it is very loose. And so these women might generate sprains in the feet that are going to fall without any way breaking the ligament. They would stand up again saying, nothing has happened. They still can walk because there is this flexibility at the level of the ligament that was sprained instead of breaking. In the plantar zone, we can see that it is involved as well. So it happens that frequently there are flat feet and sometimes cavus feet, and the plantar fasciitis is triggered. And how do we notice these injuries? Since these women cannot wear heels due to the excessive torsion, they usually wear wedged shoes, and this is affecting the plantar zone. So at the end of the day, the plantar zone is really painful. They would usually wear sports shoes, flat shoes, which are the only ones that do not generate pain. Another pathology that is associated with lipedema is ovarian dysfunction. The inflammatory ovarian dysfunction, according to our experience, affects 74% of women with lipedema. The ovaries are close to the inflamed area of the gut, so also the ovarian area is going to be inflamed. And between 12 and 20 years of age, menstruations are going to be extremely painful, up to the point that these women have to stay at home. So painful up to the point of taking painkillers. Moreover, menstruations are really abundant, and they're not do not have a 28 cycle, maybe 24 or 32, but not 28 days. And sometimes with the passing of years, the menstruation cycle is regulated, especially in some cases when women are pregnant. This is going to regulate the ovarian dysfunction. With the passing of the years, according to our experience, it's common to see ovarian cysts, dysfunctional cysts that do appear and disappear. Sometimes this is confused with polycystic ovary syndrome, because these are not polycystic ovaries. When women go to the gynecologist and get an ultrasound, this is not shown at the images. The cystic ovary is an inflammatory pathology. An inflammatory ovarian dysfunction. With a lower frequency over the years, there is also endometriosis, polyps, low fertility, and early menopause. According to our experience, we have seen that many of these patients, aged 18 or 19, had this very painful menstruation, went to the gynecologist, and were prescribed to take oral contraceptives. Those who took oral contraceptives had a worsening of the situation and a higher progression and greater evolution of the pathology. Many of these women saw that this inflammation due to oral contraceptives was extremely damaging and stopped taking these drugs, and others instead kept on with the administration, and lipedema was getting worse and developed more. %84% of women affected by lipedema have this pathology, so aged between 12 and 20 years. Another lipedema-associated pathology is thyroid pathology. The thyroid pathology is described in different scientific works. We have seen in our experience that it is 57% of women with lipedema. Usually, the thyroid pathology is present at 55, 60, or 70 years of age. Anyway, at the ultrasound in the echo Doppler of the thyroid, it is already present many years earlier at the onset of this pathology. This means that the thyroid ultrasound can be of help in diagnosing the pathology before its onset in the patients. Another disorder is represented by allergies, bronchial hyperresponsiveness. Most frequent allergy is to nickel. And here we have to ask all women with lipedema if they remember when they were young and they used to wear earrings which were not made in gold or silver. In these cases, maybe there were some irritations and that were not in gold or silver. Some stained their fingers, leaving some colors. And then, of course, allergies to pollen, dust, animal hair. Anyway, these allergies can lead to intolerances. They can have their onset, maybe not in childhood, but also in adulthood. Atopic skin is quite often in women affected with lipedema as part of the allergy. So to summarize, these 5 pathologies that we have described and mentioned are associated with lipedema with a higher frequency compared to the general population. It's going to help us diagnose also lipedema. That's my presentation. Let's move to the Q&A session.
Okay. First of all, I want to thank you very much because we have a very, very good reaction from the people that are listening to our webinar. We have so many questions that it's difficult to know which is the first one. Maybe we can start with, I don't know if you can hear Marcel or not, but maybe I can ask the first question. And the first question is concerning the garments. Is it a good motive or not to use garments?
No. Lipedema makes 2 kinds of pains. It can affect more the lymphatic system, or it can affect more the venous system. If the disease affects more the lymphatic system, the manual lymphatic drainage will be very good. The problem is that it's only for 24 hours more, but it will be okay. But if it affects, and this is one of our last investigations, that can affect the venous system more than the lymphatic system, el drenaje linfático manual, the manual lymphatic drainage, will be quite good, but the therapy will be better. So it depends what system is most affected, lymphatic or venous or both. Then, if it's lymphatic, manual lymphatic, manual lymphatic drainage is very good. But if it's venous, it's quite.
Okay, thank you. Well, what about fibromyalgia? Fibromyalgia,
Fibromyalgia.
sí, and lymphedema. Are a connection?
Es muy frecuente, it's very frequent that fibromyalgia goes with the lipedema. We have called this fibromyalgia pseudofibromyalgia. Why? Because we have seen that with our treatment, the fibromyalgia disappear completely. So if a treatment, an anti-inflammatory treatment, makes the fibromyalgia disappear, what do you have to think? Fibromyalgia was other different than the usual fibromyalgia, or the treatment will be enough for everything. Then I'm not sure if the fibromyalgia that the woman with lipedema has is a real fibromyalgia. What I know is that with our treatment, it disappeared.
Okay.
It has been described that the subchronic inflammation could be
Toglietemi lo spagnolo.
el desarrollador, el disparador de la fibromialgia.
Okay, thank you.
Talking about manual treatment, a practitioner asked before whether the lymph draining massage can be of help in order to reduce lipedema. The manual lymph draining massage is definitely of help to reduce the lymph damage of lipedema. And lipedema can affect, on some occasions, more the lymphatic system, on other occasions, more the venous system. When it affects more the lymphatic system, lymph drainage massage is way more effective, but it is more frequent that it affects the venous system. It always affects both, but generally it affects more the venous and lymphatic system, which is why the lymph draining massage, but it won't be a cure. The manual lymph draining massage can be of help with the pain, but it won't cure anything. And you will always have to use that therapy. A second question, which you already mentioned during your presentation, but maybe it wasn't very clear. How many patients with intestinal hyperpermeability did you have in your center of lipedema? Not only women with hyperpermeability have lipedema, because there has to be hereditary. If there is not inflammatory hereditary, despite they have intestine inflammability, they won't have lipedema, which means that despite having intestinal hyperpermeability, not necessarily do they have lipedema. This is both for men and women. Another question has to do is a question from the United Kingdom, England. Did you obtain the same results in the arms as you obtain in the legs? On some occasions, in the areas in which the lipedema has recently developed, it is quite easy to treat lipedema way more than in the legs with our technique. But definitely we were able to treat that in both areas. Talking about surgery, we have very diverging opinions in the world of lipedema. On the one hand, we wanted to ask whether surgery, bariatrical surgery, could be of help to fight against lipedema. It could be a solution, or what's your take on the bariatrical surgery amongst women with lipedema? Bariatrical surgery in patients with lipedema, some professionals definitely know more than I do. In our experience, on some occasions it can be okay. On other occasions, the loss is mainly in the upper part of the body, and the aesthetical results are very bad overall. And there are many scientific publications by surgeons who treated patients that way, and after that kind of therapy, only after did they realize that there was a lipedema, because there was a huge loss of weight in the upper part of the body and a little loss in the lower part. This kind of treatment can have partial results in lipedema. However, right now, it is being launched on the market a medication that has revealed effective as much as bariatrical surgery in thinning, not in localized thinning. This medication could definitely be of help for patients to lose weight, patients with lipedema. But still, the Spanish drug agency has not accepted this medication, which was accepted by the American one. So it could be available in the short term. That will help with the thinning process. Will it help with lipedema? No. I think it's going to be available in Spain quite soon because it's being studied by the European Agency of Drugs. That will help with the thinning, but it won't help with the lipedema. This must be clear. It's the semaglutide. This is the name. Right now, this is being studied in Spain as a treatment in cases of lipedema, as a treatment for obesity. FDA approved it, and the studies that we have mention effectiveness similar to bariatric surgery without all of the risks that kind of surgery involves. All of this has not been approved yet in Spain, but with some luck, with the medication, we won't have to proceed with bariatrical surgeries on many occasions. And maybe in the future it could be used. It could be used on a wider extent also for other diseases within the field of lipedema. Nowadays it's not available, but we hope that it's gonna be available soon. We are here hoping it's going to be available. It doesn't produce localized slimming. It does produce overall slimming, which is what we are looking for in the bariatrical surgery. With this medication, it could happen the same. However, it could have results in the upper butt but not in the lower part. Still, the research has not been clear. What we have so far are opinions. My personal opinion is that it's not going to be useful to cure lipedema as a final treatment, but it's definitely gonna help as a complementary treatment. And yet, it won't treat anything of intestinal hyperpermeability and all of the effects that are related to this disease, which we have already mentioned. And all of the symptoms, headache, back pain, those symptoms won't disappear. We need to deal with the root of the disease, intestinal hyperpermeability. Otherwise, it could happen that some patients had surgery in some areas of their body, and years later, months later sometimes, lipedema appears in another area of their body. Why? Because if you eliminate fat cells in that way, you eliminate mother cells, but in other areas where there are mother cells, there could be an inflammatory stimulus and there could be a further appearance of the lipedema, which is why we could have multiple appearances of lipedema. It could happen at the level of our trunk, at the level of our legs, which is why, from our perspective, lipedema needs to be treated at its roots. This is the treatment that we have to adopt. And surgery is all of what we've heard today is the result of so many years of studies, of work, scientific work. What you talked about can be tested, of course, because you gave us a thorough vision, a distinct vision as to lipedema, which didn't know anything about. Our friends from England were saying that all women, all of those who are listening to us, all of them, they can relate to what you say, to the disease that you mentioned. And it would be great if you could organize a webinar for each of them. What you're saying is so interesting to us. It is incredible what you are saying. And now let's talk with some people from all over Europe, because not all of them can go to Madrid, to Barcelona. So before considering that, what can they do? What can women do? What type of analysis could be of help to detect whether it is lipedema and not something different? And when it is a lipedema, what can they do in that case? Thanks. Two questions in one, but it was really needed. There is no biological marker for lipedema. Quite sadly, there is no blood test that can say you have lipedema. We developed new algorithms for the diagnostics of lipedema that allows, without need to carry out further tests, like Evo-Doppler, which we still do, we can diagnose directly lipedema also in young women, in which still it doesn't appear much, and in elderly women, in which it could look like obesity. With our diagnostic algorithms, with echography, elastography, echodoppler, perforating echodoppler, zone-based elastography. All of these methods helps. All of this help understand the symptom of the painful area, the false pinch symptoms. All of this helps us understand whether it's lipedema or not. And as to the treatment, which I think was your question, our personal idea is that at the end of the year we will have the right permission to carry out a clinical trial that shows scientifically what many patients already saw, that is the effectiveness of our treatment without surgery. We hope we will be able to publish this trial, carry out and publish this trial at the end of this year. We don't have sponsor, that's a big issue, and this trial would be very expensive. We're looking for sponsors to carry out this trial in order to scientifically test and scientifically prove that it works, and to be able to give a solution to all of the women with lipedema, a solution that is not surgery. Still, I think that surgery can be a complementary treatment to our method. Our treatment does work because we treat intestinal hyperpermeability. It's incredible. Each single word you say helps us better understand what lipedema is. It will be great to ask you further questions, but we don't have much time left. And hopefully our organization, the organizers of this webinar, andLINFA from Portugal, Lipedema UK, and LIO Italia, they will be available to give the contacts of Dr. Simarro. I'm sure we will receive many questions in the next few days, and if you're happy about it, you may answer to our questions. So every word you said is so inspiring and inspires many other questions. So we're gonna get all of the information you gave us, and we will give your contact, your clinic's contact, to our patients to ask their personal questions, because we have so many different questions. And thank you very much for sharing with us so many insights, so much information, and also to show that lipedema is part of the problem, it's not the only problem. So thanks to all of those who have been participating in this webinar. For any doubt, you can get in touch with me through my email, info@Instituto dell'Ipedema. We're also happy to answer on Instagram, www.clinicasimara.com. This is our website. This is still in Spanish. We haven't translated it yet, but you will be able to see the content I mentioned today. And I strongly recommend you to visit our page, because you will find the answers to many of your questions. Thank you very much. Thanks a lot. Thanks for giving us this additional information, which is completely something new compared to the traditional information that we receive. So thank you very much. So, to conclude this webinar, can you hear me? Yeah. I wanted to thank you on behalf of all of the organizers. Thanks to all of the sponsors of this webinar, HumanMed, USO, Solidea, Società, and Medicina UK. This seminar is not going to be the last. We're going to have another one in mid-July. So I invite all of you who want to participate. July the 6th, Dr. Maya Zoda, Hansa Clinic, Germany. It's a webinar on surgery. And July 12th, Burgo de Laura, Dr. Burgo de Laura, Lipomedical. And July 20th, the last one, there is the final day all together, Lipedema UK and LINFA and LIO Italia, to present the programs, because this month is going to inspire, is going to give information on lipedema, and we really hope that we can achieve some progress and good results. We're gonna see that on July 20th. Thanks.